Firstly, I would introduce Dr. Harpal and Surinder briefly, and later on, I would request you people to introduce yourself. So, Dr. Harpal and Dr. Ravi Bansal, both of them are working in this Chandigarh Child Care Center in Kot Kapura, and personally, I know about this center from last many years. Surinder, I'm just beginning with it. If you want, then okay. So, this basically, Dr. Ravi had been coming for all our meetings and all IAP and had been very active. And it's my first interaction with Dr. Harpal. It's a good center, and I really appreciate all the nurses working over there and all the centers. Some of the centers I might not be knowing, but I know all of you are doing good. So when we are working in our with preterm babies or with any neonate and in the pediatrics, if you have come to work in pediatrics, all of you know the subject. The idea behind all this is that we learn the proper method of doing the various skills which are needed for neonate, so that there isn't any personal practice in saving. It's whatever the methods we are using, the skills we are learning are the one which has been already proven, which we say in our scientific languages that there's a evidence behind the things which we are doing, right? Some of the things we do adapt according to the local facilities that are available in our setup. Uh, so now I would request Dr. Harpal to introduce himself, and then Dr. Surinder, Nurse Surinder, who is also enrolled candidate for fellowship, to begin with the first session. And this session is regarding neonatal resuscitation, how to prepare in the delivery room. So over to you, Dr. Harpal, and then you can become a presenter and share your slides also. Right? Dr. Harpal and Surinder, please. So till the time they are making their slide presentation in the slideshow, I would request, since Dr. Sushma is not available, I had requested Surinder, and if he is available, then he can just give an introduction for starting of this program. He said that he is just joining. Let me check if he has joined. Surinder,
there is some electricity issue, and we will just start in 1 or 2 minutes.
okay, so Surinder is yet to join. Meanwhile, we have our previous chairperson with us. I request Dr. Manisha, and we have our committee members who are quite enthusiastic and they all are very active members. I request our previous chairperson, Dr. Manisha, to just before we start with this session, the scientific session, to just give a brief word about all this.
Hello everyone, can you hear me? Am I audible?
Yes, you are audible.
Yeah, okay, thank you. Yeah, so a very good afternoon to everyone. And I'm really happy that we have restarted this program for this year. It's been quite exciting and quite good experience conducting it for the last 3 years. And I wish all my best wishes to the new chairperson, Dr. Jain Madam, and all the committee members. I request all the nurses who are doing fellowship, as well as those who are from other accredited NICUs who have joined, to join regularly for this program and to make the best use in order to provide better care for the neonates. So thank you very much, Dr. Suksham, and please carry on with the meeting.
Thank you. And we have with us with the other members also. Dr. Mahindra Jain has joined, uh, and rest I don't know if others have joined. And although Surinder also talked about joining, somehow there is some electricity issue that has happened at the center who has to present. I'll just wait for 2-3 minutes. Otherwise, I'll request them to join via the mobile mode. They can join via some phone also. They had joined just even before time.
Dr. Suksham,
Yeah.
that electricity issue has been resolved. So we are going to start now.
Okay. Please start, please.
Very good afternoon, my dear friends. My name is Dr. Harpal. I'm a consultant pediatrician at Chandigarh Hospital, Kotpura. Today, our NNF fellowship student, Ms. Surinder Kaur, will be talking on preparation at birth and what are the routine care we require at normal newborn. So we'll be finishing in 30 minutes. So let's start, Surinder.
Hello, can you hear me? Hello.
Hello. Yeah, yes.
Surinder, you are audible. So
Yes, sir.
Thank you, Dr. Shukshan. And I'm so happy to see so many participants right on a working day, daytime joining. 70 people have already joined here. And I can see Dr. Ravi Bansal from Chandigarh, Sarda. Yeah.
Dr.
And
Surinder, कैसे हो?
मैं ठीक हूँ सर चंगा उसी दसो and so many people. Yeah, good. That's great. So, Dr. Suksham, uh, uh, I think, are we about to start or we have already started?
Surinder, we had already started. We pitched you
Oh, sorry.
15, so we start a time. I've changed
That's
to
great.
2:15 to 3:30.
Please carry
So
on.
we
Please carry on.
okay,
And my
thank you.
wishes from Central NNF. As secretary, Madam is the president is in US right now, and she also, on her behalf, also I convey wishes to the NNF NOEL nursing committee meeting, and I think all the nurses students who are there because they have to appear in the exam in October. That exam is going to happen, and Dr. Suksham will see to it that these the cases or the seminars which have been included are somewhere gets reflected in the tests which are offered to you. So joining them, attending them will actually help you in passing the certificate course exam also. Thank you.
So please start, Surinder.
Good afternoon, everyone. I am audible?
Yes, you are audible. So please start.
Okay. I am Surinder Kaur from Kotipura District, Freeport. I am serving at the Chandigarh Child Care Center, Kotipura District, Freeport. Today I am represent my topic on preparation for newborn and routine care of the newborn in the delivery room. So let's we start. I make a PPT on the PowerPoint. I represent my PPT on front of you. So let's we start. My first PPT slide. Everyone see this? And secondly, we discuss about what the causes of the neonatal death, because neonatal resuscitation is required. When we know the causes of neonatal death, it prevent by a neonatal resuscitation. First of all, we discuss the causes of neonatal death. There is some pie chart in front of me. First of all is the sepsis. Sepsis is a main cause, and another is a preterm, birth asphyxia, and other. So whenever we give the neonatal resuscitation, we prevent the birth asphyxia neonatal because it a way to survive the baby from the birth asphyxia and preterm babies, because preterm babies require initial steps and some time of resuscitation. So next slide is, what is the neonatal resuscitation? It is very important to know everyone that what is a newborn resuscitation. It is a neonatal resuscitation is an intervention after a baby born to help it breathe and to help its heartbeat. Because most of deliveries, 90% of cases are not require any type of neonatal resuscitation, but few are require neonatal resuscitation. On that time, we give a resuscitation to that baby to survival their birth rate and heartbeat. So next we discuss the neonatal principles. Neonatal resuscitation principle. In this resuscitation, we follow the 5 principles. First, preparation for delivery. Whenever we go to attend delivery, first prepare the all equipments and so on. And second is discuss the establishment of the respiration. That is most important. And another one is the prevention of hypothermia, prevention of infection, and establishment of breastfeeding. Everyone see the flow chart of neonatal resuscitation. In this chart, we assess the first antenatal counseling, and second, we guess the term or preterm, and third, we guess the baby's breathing properly or muscle tone. Then rapid assessment is most important. First, we check the antenatal counseling. Team briefing and equipment check is important because antenatal counseling, we check the high risk of any type of antenatal risk factors. And second, team briefing is too much important because while we briefing the team, everyone know their function while emergency condition happen. And equipment check is important. Whenever baby is born, then we check the term gestations, food tone, and breathing or drive. On that time, we follow the routine steps. Then we check the neonatal resuscitation. Out of 100, within 90% babies cry spontaneous immediately after birth. There no need for any neonatal resuscitation. But only 10% of baby require some assistance at the birth. So 10% babies require initial steps of resuscitation, such as position, neck position, any type of suction, and so on. But only 1% baby required advanced resuscitation. So on that time, neonatal resuscitation program is helps to survive the rate of the baby. Then another is why is important for neonatal resuscitation and why is important for baby make it cry immediately. It's the main cause of mortality and delay milestones, mental retardation, loss of hearing or vision, seizure, and behavior problem. Whenever we save the baby, that babies cry immediately. They can't suffer these problems such as a loss of hearing, visions, any type of seizure, behavior problem, and mental retardation. So we prevent baby from these problems. First of all, we know that what's the risk factor of pregnancy. That is a maternal age less than 16 or more than 32 years. It is a risk factor because age of 16, uterus is not mature. So on that time, baby delivering is very difficult. And preterm or postterm baby, we know that the preterm baby required initial steps. So that's why risk factors is important. And multiple gestation, maternal hypertension, eclampsia or preeclampsia. We know that whenever maternal hypertension occurred, on that time due to hypertension, mother have a seizure. So on that time, baby required initial steps. Other polyhydramnias or oligohydramnias, IUGR baby, significant malformation or abnormalities in fetus, no antenatal care, major problems in mother. Risk factor at birth. We know that all risk factor because first of all cesarean section or forceps delivery. We know that whenever babies spontaneous birth on that time they not require any type of resuscitation. When baby is delivered by forceps delivery, on that time baby have a lot of hypoxia. So hypoxia is convert into birth asphyxia. So it is very important to give resuscitation on that time. And second is meconium stained amniotic fluid. Whenever baby aspirate meconium stained amniotic fluid, on that time resuscitation is required. And fetal bradycardia. from antenatal checkup, some ladies suffer with a fetal bradycardia. On that time, it is very important. And breast presentation or non-vertex presentation, prolonged labor or precipitate labor. Prolonged labor is contain a lot of hypoxia. So that time, initial steps and resuscitation is required. Significant intrapartum hemorrhage and cord collapse. Then we'll discuss the preparation at birth. There is a three major points preparation at birth. First is the team briefing, equipment check, and newborn corner. Team briefing and team member and its briefing is very important because most of all in neonatal resuscitation, 5 persons are required in protocol, but most of time 3 persons are required. One contain the respiratory part and second check the cardiovascular and CPR, cardiac pulmonary resuscitation, and third maintain the intravenous IV line. So it is very important that team briefing is done before attend any type of delivery. Team briefing, 3 must be present during neonatal resuscitation. One is the leader that contain the respiratory support, and another one is the chest compression if required, and one for intravenous medication if required, such as the adrenaline or MS bolus whenever baby, according to baby requirement. Then this image is the article need at the newborn care. First of all, suction machine, mutual sucker for suctioning the baby and aspirate the amniotic fluid and meconium, radiant warmer to prevent the baby from hypothermia, and sterile cord cutting scissor, which helps to cut the cord. That is another is a cord clamp, sterilized cotton balls to clean the wipe secretion of the baby, and measuring tape. Then is the emergency medication such as the adrenaline, NS, dobutamine, and dopamine. So on. Identify tags is very important. Clean tray, baby sheets, and stethoscope to listen the heart rate of baby, syringes, and sterile linen and gloves. Then we watch the newborn corner. It is very important in every labor room to prevent the baby from hypothermia and to check the any emergency situations, like a baby is not crying immediately. On that time, we put the baby on radiant warmer to give the breathe and to continue their survival rate. In the newborn corner, we always ensure that warm and draught-free delivery room temperature between 26 to 28 degrees centigrade is very important. A radiant warmer that has been switched on to clean and warm sheet is put on the radiant warmer. Hand washing, wearing sterilized gloves, sterilized delivery kit, functional bag and mask, functional laryngoscope and ED tubes, injection adrenaline, which is diluted 1:10,000, normal saline and syringes. This is very important before delivery. Gather equipments. Then next time we will discuss about the routine care. First of all, whenever baby is delivered, call out the time of the baby and baby placed on the mother abdomen. Dry baby with warm clean sheet. And then after that, we use the another sheet. Wipe mouth and nose with a clean cloth. Assess baby is breathing while crying. And after that, we clamp the cord at least 1 and 2 minutes with the sterile instruments, put sterile tie, because there is a few benefits which are discussed in the another slide. Put identify table on the baby. And another routine steps are examine for malformation birth injury. First of all, we examine the any malformation in the baby, such as the atresia and urethral opening is here, any type of top. So these malformation is checked after the delivery. Initiation of breastfeeding within 1 hour. Continue. Record baby weight. Give injection vitamin K, IM. Cover baby head with the cloth. Cover mother and baby with warm cloth to prevent the hypothermia in newborn. Then delivery of baby and put baby on a mother abdomen. Baby should be delivered on mother's abdomen. If baby is crying, routine care of neonatal should be done on the mother abdomen, both term and preterm. Then this is the image that prevention of hypothermia and baby on the mother abdomen.
Ensure warmth in the labor room. Prevent any type of heat loss. Close the door and windows. Switch off the fan. Ensure that
Cesarean born beginning for a expert
ensure warmth in the labor room. Prevent any type of heat loss. Close the door and windows. Switch off the fan. Ensure the labor room temperature 26 to 28 degrees Celsius. Switch on the radiant warmer at least 30 minutes before the delivery. Place two clean towels on the radiant warmer and wash it. Remove wash, vacuum, and replace. Roll up the sleeves. Wet hands and pour out with running water.
Hello everyone.
Apply. So,
Hello everyone. There are some problems in video starting. So at the ending of my presentation, I represent in front of you this video. So we will discuss next slides. That is a delay cord clamping. There is a few benefits of delay cord clamping, but in most of cases we do not do delay cord clamping. There is a few benefits. If everyone know their benefits, then we encourage the other gynecologists regarding this delay cord clamping is important. There is a few benefits. First of all, whenever we delay cord clamper applying, on that time, it gives us 60% more blood cells to that baby. That is in the another time, it prevent baby from anemia because premature babies require a lot of anemic situations. So on that time, we give the blood to the neonate. So it prevent the baby from anemia. Second of it gives the iron to that baby till 1 year of life. Baby no need any type of iron deficiency problem, and it gives the white blood cells to the baby in excessive form, which helps to baby fight infection because sepsis is a major cause of death. So it prevents baby from the any type of sepsis. And third one is most important benefits. It gives the stem cells to baby. Stem cells helps to our body it recover that organs which is near to damage and damage. So it is a major benefits of a delay cord clamping. Whenever we encourage other gynecologists and everyone regarding their benefits, so it is possible and it gives a lot of benefits to the newborn. And another is a routine suction is unnecessary. If the baby is born through clear amniotic fluid and begins breathing on their own shortly after birth, do not need suction. However, if the baby is struggling with the signs of respiratory distress, do not delay suctioning. Suctioning guideline, suction only for clear indication whenever baby have any increased oxygen needs and bradycardia and baby got in apnea and audible breathing or gasping and visible secretion of obvious difficulty or clearing the airway and any type of aspiration. Whenever we clear the secretion by gauze, after that if we visible any type of secretions sounds, so on that time suction required. Suction is not needed if baby cry and breathing properly because suction has some bad effects. It stimulates vagus nerve. We everyone know that the what a function of the vagus nerve. Vagus nerve control the motor function and it also control the heart rate. Whenever we will encourage the suctioning at birth, it stimulates the vagus nerve, uh, which prevention of baby is bradycardia and tachycardia. So it is a source of airway injury and it also a risk factor of infection and intracranial pressure. By doing suctioning, it increase the intracranial pressure with baby in the future time, baby increase the intracranial pressure and it also is factor for the baby. Care provided to the newborn including maintain of temperature is important. It prevent the baby from hypothermia. Normal neonatal temperature is 36.5 to 37.5. Establishment of open airway and circulation. Identification of newborn. Clamp and cut cord between 1 to 3 minutes. I will discuss this practice in that time. Stimulate baby rubbing the back. Vitamin K injection given to delay at the birth of baby not breastfeeding. Breastfeeding as early as possible is important. At the ending of my PPT, we observe the observational stage. In this stage, first of all, keep the baby on
నువ్వు ఇక్కడ
mother.
పెడితే వింటాం చూద్దాము.
Participants who have joined
Excuse
later.
me, so many sound is coming.
Yeah, this is what I'm saying.
Excuse me, so many sounds are open.
Malti, Manita, Raju, Sandeep, you need.
Sorry for the inconvenience caused. I am for the timing muting all. The respective speaker can unmute herself and then continue this lecture, ma'am.
Yeah,
Thank you.
so you can please mute rest others.
So we'll discuss about the observational care. In this care, keep the baby on mother abdomen in skin to skin contact and cover baby and mother together. Monitor neonatal temperature, heart rate, breathing and color every 50 minutes in first hour of delivery and every 30 minutes in the next hour of delivery. Carry home messages. NRP is very important to initiate breathing is around 10% of baby, which we are discussed. Team briefing is a key point of smoothing functioning during neonatal resuscitation and sterilized delivery kit, functional bag and mask and intubated kit must be on bedside. Labor room temperature must be around 26 degree, which helps to prevent the baby from hypothermia. And taking care of the normal babies must be on mother abdomen, which also maintain the skin-to-skin contact to the mother and baby, ensure delay cord clamping for better outcomes because there are the few benefits which we are discussing in my PPT. Okay, thank you everyone. At the ending, I am playing my video, which is not play in the front of our PPT. So last time at the ending, I am playing video. So watch my video.
Are you playing the video?
Yes, ma'am.
It's not started as yet.
Just within 1 minute, ma'am, play my video.
Okay. Otherwise, I'll begin with the discussion.
Okay, ma'am.
So, during
Prevent any type of heat loss. Close the door and windows. Switch off the fans. Ensure the labor room's temperature is in the range of 26 to 28 degrees Celsius. Switch on the radiant warmer at least 30 minutes before the delivery. Place 2 clean towels on the radiant warmer. Hand washing. Watch, bangles, and rings. Roll up the sleeves. Wet hands and forearms with running water. Apply soap to make lather. Wash hands in a sequence. Palms, fingers, and web spaces for 20 seconds. Back of hands, 10 seconds each hand. Fingers and knuckles, 10 seconds each hand. Thumbs, 10 seconds each. Fingertip, 10 seconds each hand. Wrists and forearm, 10 seconds each hand. Wearing sterilized gloves. Use left hand to pick up right glove at the bottom fold and insert right hand. Use left hand to pull up right glove without touching outside of the glove. Delivery kit. Ensure high-level disinfected delivery kit comprising cord clamp or tie and scissors, 2 towels, cap and socks for the newborn, mucus extractor, bag and mask. Check functionality of the bag and mask in 3 steps. Fit mask onto the bag. Check that the bag re-inflates quickly after squeezing. Deliver test breathes against the palm. Feel the pressure on the palm. We are prepared to welcome the new life with act care and deliver the baby on mother's abdomen. Call out the time of birth. 11:45. Thoroughly dry the baby and remove the wet towel. If baby is breathing well, place the newborn for skin-to-skin contact. Cord clamp or tie. After the cord has stopped pulsating, place 2 ties or clamps tightly around the cord at 2 centimeters and 5 centimeters from the umbilicus. Cut the cord between the ties. Skin-to-skin contact is natural warmth for the baby. Keep the baby in prone position on the bare chest of mother. Head should be between the breasts and slightly turned to one side. Place a cap covering the head and have the mother gently hold the baby in place. Cover the baby with a dry cloth. Then put a blanket to cover the baby and the mother. Monitor the baby lying in skin-to-skin contact with the mother while the placenta is being delivered. Ask the mother to support the baby. When the newborn shows feeding cues like opening of mouth, tonguing, licking, rooting, then encourage the mother to breastfeed. Adjust the calibration before weighing the baby. Record the weight. If the newborn is low birth weight and stress-free, promote kangaroo mother care to ensure warmth. Thoroughly examine the baby. Once the weighing is done, start the routine examination. Check for danger signs and take action if needed. Rule out congenital malformations and birth injuries. Cleft palate or lip. Spina bifida. Give intramuscular injection of vitamin K. Also give oral polio vaccine, BCG, and hepatitis B.
Hello, everyone.
Surinder, and throughout the presentation I've been posting, you can open up your chat also. And I had been posting questions. Some of these have been replied.
Okay.
Uh, Somehow the questions are coming from my side only. I want all of you to pose your own set of queries and doubts.
Okay, ma'am.
So nobody has posted that. So first was I asked about which mode of warmer do you use when you prepare for the receiving of baby? Because servo mode takes lots of time.
Yes.
So it is kept on a manual mode, not the servo mode, right?
Yes,
And
ma'am.
20 to 30 minutes before you have to
Yes.
preheat. Then, like you were showing also your video, how do you place your cot in the labor room? So as to prevent direct air draught to come, to prevent that convection current losses. So what should be the direction of the cot with respect to your entry door?
Yes.
Anybody? So the cot has to be kept at 90-degree, not parallel to the wall. So this will prevent your losses by radiation of
Radiation.
heat
Yes.
wall. And in order to prevent convection losses or air current losses, you have to keep it at 90-degree from the wall. So not parallel to the wall, 90-degree to the wall, and it should be
वाईफाई
up.
वाला हो ना वाईफाई वाला जो ऑप्शन आती है वो ना नीचे वाले ही ऊपर वाला
Please,
ऑन
rest of you mute yourself. Lots of you have not muted yourself, interfering with the discussion. And it will be really, I mean, uncomfortable by pointing by names that so and so person is unmuted. So please mute yourself so that others are able to understand what we are talking. So the door, the bed should be, the baby cot should be away from the cot, from the door, and it should be at 90-degree. And then we began with other questions. Some of you have replied on the mode, on the vitamin K. Vitamin K has nothing to do with the fact that baby cried or not cried.
Yes.
So it is to be given to prevent what? Can anybody tell? To prevent for why we talk of universal vitamin K? Against hemorrhagic disease of newborn, which is of 3 types. So you have to give vitamin K. Okay. And dose obviously vary as per the weight of the baby. So there are only two doses, 0.5 and 1 mg, less than 1000 or more than 1000 gram. Then I talked about, can anybody brief about by typing or so, components of antenatal counseling? Usually we don't talk of it, we simply write down do antenatal counseling or do the counseling. There is always a call that so and so high risk mother is there, and the team of pediatrics should counsel the parents. Has anybody done it, and what are the components of it? Anybody?
Ma'am, actually, we discussed in that the cost involved in that, and first the outcome of the baby. If there's a high risk cases or in a preterm delivery, there's risk of an ICU stay, the duration of
Yeah.
stay, the cost involved. We have to counsel all the aspect to the patient.
So good. We talk about that how much time they will be likely to staying in the hospital, because everybody is worried from, if it think from the family perspective, that what is going to be a prognosis, how many days one has to stay, and what will be the approximate cost. So you have to also talk about prognosis, but don't keep on talking about very long prognosis of later on of the life of 2 years, 10 years, because they are not going to understand too far from now. It has to be told, but not in depth. And we keep on talking out of 10% will survive, 15% will survive from the literature. Please don't talk from the literature only. Talk of survival at your center. Suppose there is a baby who is to be delivered and estimated weight is 1000 gram, 28 week. So if your center is not well equipped, please do inform. Don't talk that 1000 gram 28 weeker has got 80%, 90% survival, which may not be true for your center. Okay. Then we talked about team briefing. So just how do you brief your team? In your PPT, you talked about respiratory therapist and all those. Do we have such persons in India? We don't have, right? We don't have a separate respiratory therapist. We don't have a separate person for three types of activities you mentioned. So how many persons are needed in a delivery, which is a high risk, and how do you brief them?
Most of all, ma'am, 2% is required for attending delivery. 1% deal with any type of critical situation. One is help. One is give help to another equipment gives. So 2% is required for every delivery in our center.
Actually, ma'am, actually we need at least 3%. One for respiratory support, if any required, or as a leader, and a second one for any chest compression or any cardiac support, and third one for any intravascular injections or any documentation.
So it's
So we
correct
need
if
at
you
least
don't have
3%.
So if you don't have three persons available, you can go ahead with the two, and you
2%.
can keep the third one ready in the back
Yeah.
end. So you can always communicate that you might be needed. Okay, and the call will be given, because making 3% stand for a single delivery, which may not land up in chest compression, because only 1% is going to need chest compression. So you can't make for every high risk delivery 3% stand on the head. So you start with the 2%, and you are doing back and mask, and you are finding that the response is poor. Now you have to intubate. So you can keep this person in the back end, and the call can be given by the labor room team, maybe the obstetric team, to this third person. Good. So you have to tell as a team leader that, okay, uh, do you know the resuscitation? This person says, no, I don't know the resuscitation. Then that part is not given. Firstly, you have to know what is the level of skill of the person who are there in the delivery room. You may assign a nurse that you have to do chest compression, or you have to do bag and mask, but she is a new nurse and she doesn't know how to do bag and mask. So you have to also understand the skill of the person concerned before you assign. So the leader assign as per the skill of the available person, that this activity has to be done by you and this activity has to be done by me, so that there is no confusion once you are making the resuscitating the baby. Then it was just spontaneously, I was typing some more questions, components of briefing. So one was about how many drapes do you need when you go for delivery room preparation? Autoclaved drape sheets, how many of these are needed?
2 sheets are required, ma'am, because one sheet whenever baby is
So
delivered, we clear the
we need
secretions and amniotic fluid from the baby and use the another sheet which prevent baby from hypothermia and cover the baby's another sheet.
So we need three autoclave sheets. One is on in the warmer. One is in which you receive the baby. The sheet in which you have received the baby is removed, and baby is wrapped in the another autoclave sheet, because the sheet in which you are receiving the baby becomes wet. So you have to remove that sheet, right? And then for the babies who are small, how many of you are using plastic wrap to prevent hypothermia?
Yes, ma'am.
Have you heard
Yes,
of
ma'am.
plastic?
Whenever baby is delivered preterm, so on that time, plastic paper is important because it helps to prevent hypothermia. Premature skin is there is a no fat, brown fat. So on that time, plastic wrap is very important.
So we need a plastic wrap for definitely for all preterm babies, preferably all less than 1500 gram. And it's a food grade plastic wrap. Okay. And you don't have to cover head. So head is with this plastic wrap. You have to put the baby, you may even slip in the baby in the wrap without drying the baby. You take the baby in this wrap from every part is covered. You wipe, and the face is kept open so as to assess. Neck and rest of the part without drying is being wrapped in plastic wrap. And maybe some of you can look into the photos and the videos of the plastic wrap. Somehow they were not there in this. Then there was something which was, please, I request rest of you to mute yourself. Rest of you to mute yourself. And the presenting side, please, rest of you should be muted. And there's a Monica Carle who is not muted. Shraddha Palekar. It doesn't look nice if we point out by name that you are not muted and your sounds are coming in the background. Please. So now you didn't talk about the pulse oximeter. So all of you should keep ready with your pulse oximeter. If the baby hasn't cried, then we have to apply the pulse oximeter. You must have seen in the flow chart, there was a nomogram. So you have to monitor the baby's heart rate saturation. And the pulse oximeter is always applied in the right hand of the baby because although right and left both are preductal in less than 24 hours, but right hand represents the preductal saturation. Now, I also talked about the suction pressure. You gave me the correct answer, what should be the pressure of the machine, but nobody told me how much is the maximum pressure a machine can deliver. So our wall suction,
Maximum pressure of suction machine is less than 100 mm because more than 100 is it.
no, I'm asking of the machine. I'm not asking for which you set for the baby. So if you go and check your machine, the maximum pressure which this machine can deliver is 300 millimeter of mercury. That is why it is mandatory for all of you to check the pressure. Because the wall suction pressure has a knob. Whenever the sweeper comes and clean it, he rotates it because he has to clean the knob. And it becomes at 300 millimeter of mercury. So all of you, when you are, it's a part of preparing for your delivery room, that in every shift you must check your suction pressure, that it is at 180 to 100 millimeter of mercury, because the maximum which it can deliver is 300, and this is one of the most common hazard which is happening in the delivery room. Ambu bag cleaning, you people told correctly that after use it has to be cleaned with soap and water and then soaking in either 2% chlorhexidine for 20 minutes, or you can send it for ETO or autoclave. Autoclave somehow discolors it, but if you don't have ETO, then send it for autoclaving. Okay. Now, I also asked about flow rate, which is more or less has been told correct, in between 5 to 10 liters. And I hope all of you are practicing your resuscitation of the baby till bag and mask step or not, because that's mandatory for anybody. This is till bag and mask stage, it is basic NRP, which is expected out of every nurse. Are we practicing it or not? Till the stage of bag and mask.
Whenever baby is not breathing, on that time bag and mask is started, PPV, positive pressure ventilation. First of all, we give the
No, I'm asking, I hope all of you are doing it. All of you know it, the correct steps. Bag and mask. How do you do the bag and mask?
breathe, 2, 3, breathe.
Yeah, I'm just saying that all of you know it, I hope. And in case you are not having a baby who is needing it, you should, all of the centers should have at least one baby Natali, whereby they can practice on this bag and mask activity, right? And then DCC. If you are not doing DCC, you have to. I don't know. Some of the center has again started with the noise. I think it's your video which has been put on, Surinder. Please switch off your.
और पूरी जब मैं गई थी मैं उसको 3-4 बार बोला था चल खाना खाने चल खाना यही रहता अब जाओ उसमें एंट्री डाल दिया मैंने आयशा में एडमिशन पे डाल दिया मेरे पास इनिशियल जो न्यू बोर्न असेसमेंट है वो भी सेम ही करनी है उसकी भी
Some of you
बस वहाँ पे
my God. You need to unmute yourself.
अन्नू टाइम देख रहे हो क्या हो गया
Some of you are not muted. Chandan, Claminica, Daisy, Gun, and all the participants of the end are not muted. Vitali, Manita, Daisy, all of you are need to mute yourself. So, Ritupuran, can you mute them? Can you mute all of them?
Yes, ma'am, doing.
And Urmila demand she is active voice. Please mute Urmila.
रोल होने वाली क्या बात है मैंने उसको साथ में गई ना मैं उससे पहले से गई
Ma'am, I have muted everyone, so the speaker can unmute and please proceed. Thank you.
So please mute most of these people. They have put on lots of noises. So now we were discussing about checking of the suction pressure, checking of the flow rate, and DCC. So DCC is a standard of care. Not doing DCC is deviation from the standard of care. So this DCC has to be done in all the babies who haven't cried immediately after, who have cried immediately after birth, term or preterm. But if not cried, still the guidelines are pending. So you have to at least do delayed cord clamping in all the babies who have cried immediately after birth. And any one can tell me about birth companion? Birth companion? So one of you have put the question from Jyoti Patodia, putting baby on mother's abdomen in case of LSCS is not possible. So in case of LSCS, obviously the abdomen of the mother is sterile, but there are two methods which people are using in these cases. Squeezing is not the answer. That umbilical cord milking, the word is not squeeze. It's umbilical cord milking. It has a proper procedure. It can't be done just by simply squeezing it with hand, because it will rip off the umbilical cord. So umbilical cord milking, if it is done at a length of 20 to 26 centimeter of the cord. It is done 3 to 4 times. Each stroke of milking it from top to bottom takes 2 to 5 seconds. This is one method. Another is there is a special type of baby trolley that is there. We are using that. If you don't have that, then you can go for umbilical cord milking. And some of the centers, they have made a provision by making the baby lie by the side of the mother, or now hardly anybody is getting midline incision. All of these are fan and steel incision, which is in the lowermost part of the abdomen. So they are putting the baby on the abdomen. So it all depends which type of incision your center is giving to the mothers. Is your center comfortable in putting the baby delivered by cesarean by the side of the mother? Do you have a separate trolley? This trolley was designed by our own center. We are using it, and now we are using it in a very big trial also. It's a multi-centric trial. And if you don't have that trolley, then you can think of putting on the mother abdomen, because it's a fan and steel lowermost abdomen incision, not central. If central, by the side of the mother. If both of these are not possible in your center, then it's not squeezing, it's umbilical cord milking. 20 to 27 centimeter of the cord is milked from up to below with a stroke of which lasts for 2 to 4.
last year का I have to see
Anybody else for any other question? I talked about baby companion. Can anybody tell me about baby companion? Baby companion. Can anybody tell me about baby companion?
health checkup also you have to take
Basically, birth companion, not baby companion.
yeah, just go with the NBA number there it will be. Okay. I'll just give to them. So great.
Manita Dakar, you are continuously this is
Go to the cupboard.
Ritupuran, please mute all of them. Please. Ritupuran, please mute all of them. They'll
Ma'am, they are muted, ma'am. Kindly unmute.
So I am unmuting myself. Please mute rest of the others. Jyoti, you had raised hand. Somehow you can just type your message. I think rest are muted, so raising the hand won't do. You can put it in the chat. My chat box is open. You can put it in the chat. So embu bag, yes, Gayatri, very well. That embu bag, all the parts has to be checked. Proper valve has to be checked, because if this is not working, then the baby will land up in pneumonia. The entire embu bag. It's not with the all the parts like assembled and then you are cleaning. So you have to disassemble it, dismantle it, clean it, and re-put the parts. And pressure valve, it should be checked before actually using it on the baby, so that you don't land up in creating pneumothorax. Any other question? It's not coming. Baby not crying, cord milking. Baby not cried, cord milking. So baby not crying, cord milking is not a standard of care in babies less than equal to 29 weeks. It's not done in preterm babies. More than 29 weeks, it may be done. But you have to learn the method. Don't squeeze like this. And in case your center is allowing for the birth companion, because as per WHO, birth companion is a must. Any other questions from anybody? Documentation, yes, documentation is important. After the resuscitation, you have to make your own resuscitation performer. And if you don't have your own resuscitation performer, you can take from the centers that are using it. We are using a very exhaustive one, whereby we are putting not only Apgar, but the entire expanded Apgar. And because in Apgar, the fallacy is you grade it after every 1, 5, 10 minutes, 5 minutes. Whereas the event may happen by 3 minutes, you have put off your PPV. So we are writing down all activity for first 10 minutes as and when they are reached. So we are using expanded Apgar. You can design your own resuscitation performer, document it, and in case the resuscitation was done, debriefing is very important, so that you are able to realize where did you all go wrong, and that can be prevented later on. Anybody else for anything? Any other questions? It's not baby companion, it's birth companion. So the term is the birth companion, and they should be present in all the delivery as per the WHO classification. It's standard of care. Anybody? Any other? Any other from Dr. Harpal, your unit? Surinder, anything else you want to discuss? So another is, I would request all the centers that are receiving the baby, they can put a A3 chart of neonatal resuscitation, colored chart in front of the eyes, so that you don't miss anything. Because whatever is there in front of the eyes in PHCs, they are using the chart which was used during helping baby breathe study. And since you all are working in SNCUs, you should use the NRP 2020 chart, not A4. Please print it on a A2 bigger sheet, so that, and a colored one, it's in front of your eyes, and you are not going wrong in resuscitation. And in case you're not able to use bag and mask frequently, so please try it on the mannequin. Task allotment, it is done during when you have already talked about it. Legal standing of attending delivery by fellowship nursing. I did not get your legal standing. What do you mean by legal standing? You are a healthcare worker if you are on a duty. If you are already on duty, then you have to be there. There's nothing like legal standing of attending delivery by a fellowship nurse.
Dr.
Are you
what I
trying to
want
say
to ask,
you have to be NRP certified? You have to
No,
do a neonatal resuscitation program.
what I want to ask, if a nurse with a fellowship went to attend delivery to some hospital and if something happened, what is their standing?
To some hospital, I didn't get. See, when you are not trained, you are an observer. When you are trained, you have to do it. So you have to do an NRP course, and then you are trained. You can use, and the training certificate is not given to anybody without assessing the skills. So they have to demonstrate the skill. It's a practical assessment exam when you are doing the NRP. It is not given without assessing the practical. Although the skills are assessed on merits, they can't be assessed on PD. So once you are a certified person, you have to use, you can do it. And once you are not a certified person, then you are an observer. You have to observe it in the presence of the one who has done the train, who is already a trained one. I hope I could answer. I could make it clear. Anybody else? Anything? Any question from the other teammates of the NOEL group, of the attending nurses? Calm, cordial environment, not threatening, and unified communication, supportive, respectful use. Please, thank you for effective communication. Thank you all. Anything else you want me to cover? So debriefing, in case you did a resuscitation, so please do debriefing also. This is what so that all of us understand where we did go wrong and which could be prevented in the future instances. So in case there is no other question, we should, I think, close this section. I had purposefully kept it for 1 hour because what I believe, instead of 1.5 hours and all, what I know, again, the evidence based, human brain cannot concentrate more than 45 minutes to 1 hour. It's a proven fact. So keeping for 1.5 hours, the conventional, what we also used to do during our MBBS, a class of 2 hours and all, is not a correct thing. Because concentration of the human brain at one go is never more than 1 hour. So in case there isn't any question, I can't see more questions in the chat. So I would request the organizers to allow me to leave the meeting, and I'm thankful to the presenter, Surinder, Harpal, Dr. Ravi, and all. Thank you all.
Thank you, ma'am.
Thank you.
Thank you.
Thank you. Thank you so much, dear doctors. So if there are no further questions, can we bring the session to a conclusion over here now? So with all your permission, dear doctors, we are ending the session over here today. Goodbye. Take care.